and bore the pictures as a recording batless when I add this on at the beginning, so don't you worry, they haven't missed out on this. It's not boring background information, but it's important for you to be aware of. National Digital Health Strategy that will be across all states and for all Australians. And it is to ensure that all healthcare providers are on the same standard and capacity, and to be really critical for Aboriginal and Torres Strait Islanders. We don't want them left behind. This has been the primary health networks are responsible for delivery, and we have been contracted to introduce and implement electronic prescribing with active script lists, and we'll be working with you to support the implementation and understanding of real-time prescription monitoring. My buttons. Which ones? Come on. Now, the digital health strategy is not just around a medication. It's got lots of things in it. It's all super exciting. My health records, secure messaging, interoperability. Now, that's super fun because that Communicare will be able to transfer electronic referrals, for instance, to SA Health. So that's what interoperability means. It means that your system is going to work with other systems. The exchange, and that's what we'll be using to support electronic prescribing systems that ensure your prescription is electronically accessed in a real-time circumstance at the pharmacist. It's a type of prescribing dispensing system, and using technology for patient access and safety, and ensure that the admin and clinical staff are upskilled, but also there's going to be patient education available through these programs. And you'll be seeing the implementation of this device as being a critical tool for healthcare access and enablement. No Aboriginal patients will have a mobile device, but mechanisms that are put in place will ensure that carers can be linked to them and their details can be used to ensure that they also have access. So it's good for us as providers, makes our life easier. Most importantly, it's good for the patient. Patients can presume and will have better visibility of their own health record, and can ask their healthcare providers to be more accountable about their health records. Now, when we talk about prescription monitoring, one of the things that's going to come up is, it's just focused at one particular sector. It is not. Prescription is focused, is for all Australians. It's systematic equality with electronic medication. Avoid adverse drug interactions, means that people who travel will have much easier access to medications, and it will also help us to identify those patients who use scheduled medications for genuine medical needs. Amongst the preceding or obvious National Digital Health Reform Strategy, we've got these pressures that are really pushing in and enhancing the need to do things. COVID, obvious parts are. COVID has really pushed telehealth, but when we have telehealth, we need electronic prescriptions. We're going to see changes in how we have information from the Department of Health, and so there's going to be some real systematic changes. Really strongly recommend that all healthcare providers get their own pro account, and we're going to manage future access to the Australian Immunisation Register, for instance. These are factors that are going to be system changes that we need to be on top of. SA is going to put in place secure messaging. They're going to send you discharge summaries by securely. It is already configured and integrated into secure messaging, and it will receive discharge summaries automatically into the mailbox. No shock, it's true. So yes, we're going to get discharge summaries from SA Health. Better still, you will be able to send them electronic referral forms halfway through next year. So huge health reform with SA Health, terribly exciting, and will certainly enable and enhance access to Aboriginal health services. And AA reform. And now that, I don't know whether it comes to you. It comes across to Aboriginal health quite a bit. Use some home community care providers, you have some aged care facilities who will be having to respond to the Royal Commission for Aged Care. It's really important that your elders and those people in those aged care institutions, they be impacted around these health reforms as well. And this is something that's happening in 3 years' time, something in the next 6 months. Electronic prescriptions for tokens have started being used in South Australia now from November. Community care, I understand, is meant to be going live early next year, and as soon as that does, we will let you know. We will see the active script list, which I will go through later. They have prescription tracking implemented again. I will discuss this. The Australian Immunisation Register, online medication charting in residential aged care facilities, and secure messaging rollout. So we're going to be busy bees at this end, and our job is to support you through all of these processes. So what are electronic prescriptions? They are moving from paper into digital. The script will always remain available for you. Mean that your patient, instead of receiving a paper script, which I inevitably use, will receive a token on their mobile device or as an email, which they'll be able to use as their prescription. A token and the active script list, and a little thing on the side which basically says they computer system sends it into the prescription delivery service, which sends it to the dispensing service, and the community pharmacy can dispense it. So there's a little flow chart there which tells you how it works. But don't worry, I'm going to give you more information just in case you didn't get it the first time. What does it mean to the patient? This is what's important, the patient journey, and for you to be able to explain and understand the patient journey is what's critical. Visit the doctor. The prescriber is going to issue a prescription to them. Save a text message which will have their token on it. On them will be no identifiable information. It will just have the name of the medication. Patient gives the prescriber their carer's mobile phone number, and the token can be sent to somebody else in the family if they don't have access to a device themselves, or and request the token be sent straight to the pharmacy. So we know in some of the, I know that in Sajuna, it may well be that the prescriber can send the prescription straight to Ken at the pharmacy next door to Kotlia. Takes the token to the pharmacy. The pharmacy will dispense the medication to the patient, and then they will also send the patient the repeat token. So they can actually repeat token to the patient on their device. In Australia, we've been enabled as of November 2020. You will now receive a check. You'll be offered this choice when you see your providers. You'll receive a token for each medication. So if you have patients, you'll get 6 tokens. 6 medication per token, to be completely clear. Choose which pharmacy you go to. Across our country areas, the majority of our pharmacies are now ready for dispensing. Please make sure you understand that paper scripts can still be issued, and in terms of administration, it's very important that community care captures your patients' mobile numbers and your emails. Now, I'm going to quickly flag teenagers. To seek medical services which they may not wish their parent to be there, and be asked to prescribe it to them and to maintain the confidence of that prescribing. In that, you would do what you would normally do in terms of due diligence, but please make sure that it's the teacher's mobile phone number to whom the prescription is sent. So that some people in that transition age group, that the prescription, the mobile phone number that's captured for that young person is theirs and not their parents. This is where it's super excited, because the impact on this and the benefit for those people who currently get closing the gap for PBS, for instance, is just going to be extraordinary. Then your patient registers for an active script list. It's that when they go to receive a prescription, it goes automatically onto that script list, and then when they see their local pharmacist, the pharmacist can access all of their prescriptions at once, or trace down 8 or 9 different pieces of paper and various repeats will no longer be an issue. It will be this beautifully maintained active script list. It's going to be beautiful. The fact is that with closing the gap in access to medications, one was payment. Closing helps pay for the prescription. The second problem was, where was the damn prescription? Electronics essentially mean that you can't lose it anymore. It's going to be on an active list. So prescribers and dispensers will be able to view that list of prescriptions, and it will only obviously be available for viewing for a healthcare provider with whom you are visiting. It won't be available for anybody to just randomly see. The active script list will only be visible for the healthcare provider with whom you are currently in contact. Also, the pharmacy will dispense against that list. So it is extremely exciting, the idea of the active script list, but this is where I do see that it's going to be of significant benefit to Aboriginal clients. So it's going to be important that we have your support to assist them or to ensure that they register for this. It will require patient registration. Oh, I just said super exciting. When they do register, they will need their Medicare card number and some ID. They will only need this identification information once. If they go to a new pharmacy later on, they will be asked to confirm their identity in order to access that list, please note. Of lost tokens, it assists medication management and adherence. We know that many Aboriginal clients are on multiple medications, and this is going to be brilliant. Patient care will be available, and there will be some mobile applications that patients can use so that they can actually look at what they have, and they can actually also set these applications up to receive notifications as to when their prescription is going to run out, for instance. So do perceive that in the future there is going to be some work where you might help someone set it up. They get notifications when their prescription is going to run out, and how they can be best involved in accessing and managing the medicines for themselves. Now that's going to be a bit of a choker. This is the one that is going to cause questions and prescriptions. What's in the test? What's in the latest script? The active script list will show you your chronological list. So see all of your you'll see your current list that's on there. When the patient first registered for an active script list, there will be some reconciliation where prescriptions are transitioned into the electronic prescriptions and put onto the list. But the latest scripts will be available on there. Tokens or repeat prescriptions will automatically when you use the first repeat, it removes, and then it says 3 left, 2 left. The tokens themselves and also on the active script list will always let you know how many repeats are remaining. I hope that answers the question. So, the prescription machine was implemented in Victoria between 2018 and 2019. Last year was when it became mandatory. It's an automatic application system that enables providers to get authority numbers for S4s and S8 medications, but not only does it do the approval process, it also provides an instant and online of that person's current prescriptions and dispensing for S4s and 8th. And pharmacists are obliged to act on every notification. So if they receive an alert, they have to determine what they're going to do. Are they going to dispense or prescribe? And they have to say what their clinical decision is behind that. This is in place. We have approvals in place for these medications. This is an approval process which will essentially ensure that it's current and aware of the current patient situation. It's in and will be introduced from March next year. Now, just here, prescribing is not to necessarily monitor the behaviour of the patient, but it's there that the prescriber has mission to make the best clinical decisions with the patient. Introduction of real-time prescription monitoring to prescribers and dispensers, education around appropriate discussion with patient, choice for the patient, education for the patient and diversional therapies is required. Introduced a monitoring program for Schedule 8 medications without also ensuring that adequate education and options for diversion therapy are also in place. The next is unequivocally known. It's a no-brainer. Everyone knows that there is this need. It will reduce doctor shopping and unintended oversupply of controlled substances. It will systematic equality, that is, everyone's under the same rule here. It helps identify people who use scheduled medications for genuine medical need and they continue to access them with medical need. That prejudgment or that concern is removed because the genuine medical need is known to the drugs of dependence units. It will be included in the approvals that go back to the prescriber or the dispenser, and the judgment is taken out. So genuine medical need is met. It has potential to reduce harm from prescription drugs, including deaths from opioid poisoning and benzodiazepines. Other group that you may not be aware of is that what we call the opioid naive group, the young people who have a sports injury and then are introduced to opioids. It's really going to help to monitor their use at that very early stage and ensure that addiction can't occur. And so decrease hospitalisation rates. Yes. I've had a question, Peter. Yes. The whole point of real-time prescription monitoring is that the prescription goes into the National Prescription Exchange Service. So we ask for an authority on S4 or S8. Your approval will be based upon not the prescribing and dispensing wherever they've been. So if they're from Northern Territory, in South Australia, you will still see their prescribing and dispensing history. In South Australia to New South Wales, where they're also introducing real-time prescription monitoring, you will see their dispensing and prescribing history. Monitoring is working from the National Prescription Exchange Service, and from that you will see all prescribing and dispensing. So absolutely. Now, I hope you guys are positive about this because I think it's got some huge benefits for our communities, but also a really good opportunity to ensure that genuine need is met and respected, because that is the most critical part that we need to ensure goes on. So what I'm asking, and I'm really hoping you guys can help me with, is that I'm the pilot group, I'm on the panel. The program to be successful and to ensure that patient choice and voices are respected, we need Aboriginal and Torres Strait Islanders to be included in the patient evaluation process. So we back and ask you, are there any patients who are willing to evaluate the outcome of this into next year? We want to make sure that in its implementation, no one is disadvantaged and that any inappropriate behaviour is stomped on immediately. We also want to ensure that adequate education and information is being given at the MSs to ensure that you feel confident in supporting it and knowing that your clients are treated well. Across these three areas, did they affected? Did they understand the information that was given to them? Were provided options for care? So, I don't want to bore you all batless. We would love to follow up with you early next year, some more information around how it works in Victoria, be a bit more of a deep dive into SafeScript and how it works in Victoria, because I think it's awesome. In Victoria, for instance, messaging has been focused upon a sports person who's had an injury, opioid leave, and the monitoring that then occurs around his opioid choice. And the language is very positive. This is what we're doing to support health outcomes for you. This is how we can support clinicians to make better choices for your health care. This is the messaging that goes into it. This is the reason why we're doing this. For listening to me battle through medication safety changes, you have to admit it's pretty damn awesome. There's been a couple of questions. Does anybody have any more questions? That's back to closing the gap. Does anybody want to fly up or put anything up around what's in the gap? Are there any issues that you would like to raise with us that we can assist you with? Floor is open. Everybody, that would help, hey? Any questions? I muted you. Oh, Peter, you muted yourself straight away. Sorry.
Can you hear me, Sarah?
Are you Tess?
Hi. I'm just wondering, one of the problems I've got with Close the Gap, I join people up to it. We give out all our drugs under S100, so we just give them out in the clinic by sachets or by dose sets. But that affects people that maybe go down to Adelaide for a break and have to go to the AMS down there, or they maybe go to a GP. They often me and say, "Oh, look, the doctor hasn't put CTG on the script." And I say, well, you have to ask the doctor to do that. Sometimes they ask me for a number, but I never get a registered number for the patient when they go on to the CTG.
Registered numbers, not a problem.
Should I be getting that from somewhere, or is it on Proda? Is there a number on Proda that they are getting?
There's a number yes, there should be a number. I will double check that where it is. Is that a phone call? Somebody helping us out there? No. Follow that up.
Can you hear me, Sarah?
Yes. No. Yes.
Yeah. Sorry. I was just going to say because there's an individual number that's produced every time a prescription's written on that particular script. Is that what you mean, or that the patient themselves has a different
number?
Anyway, so I just wasn't question in the middle. So I just wasn't sure what you meant there, because I know that when you're dispensing a script at the community pharmacy, that it's each prescription has a different CTG number that's produced on the prescription itself, but that's not really relative to the patient. And when we register the or any patient's details into the community pharmacy program, it's just a tick in the box. It's not actually a number. So,
right. Okay. Yeah. So if the doctor's just put Close the Gap program and the patient is registered on IHI program, they should be able to get that script.
Good. And there used to be, and so correct me if I'm wrong, because I haven't worked in community pharmacy for about a year now, not regularly. There used to be a number that you could enter as a CTG number for that prescription as a handwritten script if it wasn't actually written. So if the patient was registered as a CTG patient, unwritten, or the doctor had just written CTG without any particular number next to it, you could actually use a particular identification number on that.
Yeah.
A while ago, and I don't know whether that's still relevant.
I'll just double check the CTG options on the prescribing buttons for best practice and medical director, and I think it might be worth us just refreshing our GPs once they're activating for electronic prescribing, that conscious of how to include CTG access at the same time. Yep. So there are quite a few prescribing events that will be coming up, and I think it would be a really good option to include that as we do that as well. Yeah. And MD. That's going to happen with active script lists, which probably you won't know how much it will impact you or not, but some of the recommendations to Royal Commission for Aged Care will be the online medication charting platforms in residential aged care. The active script list will work with those to auto-update the dispensing and prescribing records for patients, which will be very useful. So I'm thinking, the biggest difficulty is going to be those patients who transition still between state borders or regions, ensuring consistency for them. Yeah. So if no more questions around the super stuff on medication safety, I'm going to hand you over to Vatan to do some information regarding to telehealth. Look forward to meeting you all face to face in New Year.
See what I said?
Yes, I'm sorry.
Awesome. Thank you much. Well, thank you so much, Sarah. That was a very, very nice review of what is happening with medication safety. Please allow me to begin by saying that I am proud and honored to be virtually meeting with all of you on the ancestral lands of the Kana people, and I'd like to pay my respects to all your elders and all their elders, past, present, and emerging. Technology is advancing in facet of our lives today, and care is following the same direction. So hence, here I am talking to you about telehealth. And the news with you, which was announced about 3 weeks ago, telehealth is now a permanent part of Australian healthcare. The temporary MBS items are being continued, not only the biggest silver lining of the COVID-19 cloud, but also the biggest reform in Medicare items history since they were started. With this said, I believe it's important to note that telehealth is not a replacement for face-to-face consultation, but rather a companion which will go hand in hand and will improve patient access to healthcare. Consulting or video conferencing is used immensely in social media to stay connected with family and friends. COVID-19 gave us quite an opportunity to use it within healthcare. It will shock to you that phones are used much more than video calling. Just they're easier and require lesser effort. It is a matter of pride that ACHOs around Australia have restarted to own the concept of telehealth, using it as a tool to provide care to those who need it when they need it most. So let's talk about some genuine problems we've been facing recently. We reduce avoidable hospitalizations by increasing access to primary healthcare providers and specialists. It is noted across the board, whether I'm talking about mental health or geriatrics or chronic disease management, has consistently decreased one of all avoidable hospitalizations. So % decrease across the board. And with many pilot programs, the overall uptake of telehealth has been quite low in South Australia. Facing and moving our efforts towards our how can we turn to using more VC rather than just going telephone all the time. Telehealth in itself, it can be confusing because tele often with telephone. So people usually think that that's the first thing to go to when you're talking about telehealth platforms, but that is far from the truth. It's the hottest selling for telehealth, but mostly it is only because it saves time and money. It also reduces the emotional and social distress of traveling because of commitments that the patient might not be able to keep due to traveling. Aboriginal and Torres Strait Islander patients the opportunity to remain in a culturally safe environment with all of you when our Aboriginal healthcare providers and workers are available with them. However, it is important to note it is subject to consent. It also eliminates the loops that a patient has to jump through when benefit from SA Health's Patient Assistance Transport Scheme, or PATS, as we all know it. Another reason that telehealth is a good idea on the provider side is that travel budgets of integrated team care can be better utilized for actual patient treatment and support. Of traveling, I think it's time to look at the bigger picture in digital health. Since this are things mentioned by Sarah earlier regarding secure messaging, e-prescribing, and medication management all go beautifully hand in hand. Imagine where video technology allows patients to have access to doctors who are unable to reach them physically. Technology allowing safe and encrypted information sharing between specialists and GPs and diagnostic technicians, and also the system promotes safe medical management, everything happening simultaneously at the same time. Such a system would be a great method for appropriate sharing of responsibilities, where all of us have roles which are well defined. I'd like a couple of special mentions to our current telehealth champions in the Aboriginal community, being Umna and Nanava. We have the rock star Tess with us here, who was kind enough to share and who's always been an advocate for telehealth. Off with Umna. I had the pleasure of speaking with Carmela from Umna yesterday, who is the registered nurse over there with them, and she said that Health Direct was found to be a good platform to use for patients. Most are capable of VC, and nurses have been extremely empowered almost because they weren't doing assessments on patient end, and they're being guided by specialists or doctors who have been unavailable to try and be there. And through VC, they are being able to provide assessments. So those patients have been grateful for access to GPs even when the doctor was not fully available. I'm a long-time advocate for telehealth in the use of chronic disease management, and they were already thinking of starting it before COVID-19 happened, but it's just a trigger to get everything in place. I would not like to put Tess on the spot here, but there was a beautiful story she shared yesterday with me. Tess, were you able to share that with all of us right now?
I was just saying to you that with a lot of really good positive things go on with telehealth. A lot of patients, especially our mental health patients, really like it. They don't feel intimidated. They often get very animated when they're on it and are very interested once. And a part of it is that they can see themselves and they really feel quite interactive. But one of the ladies I had was an elderly lady, had a lot of mobility problems, had to use an electric wheelchair, and was very resistant to coming into the clinic. Didn't like coming into the clinic, found it quite confronting. Hadn't been into the clinic for checkup for about 6 months, in fact. And in fact, we used to just go and visit her. I used to encourage the nurses to go and visit her at home just to make sure she was all right. But she lived in a little wheelchair about 100 metres from the house. So I took the iPad and my phone and I did the telehealth with the physician, Sue Crail, at Adelaide. And it was great. One of the good things was Sue already knew this lady. So the lady was Margaret was quite happy to talk to her on the little TV. They call it a little TV. And So she did, and she was very interactive. And what the spin-off was that we did a good assessment of her, but the spin-off was 3 months later when I wanted to see Margaret, she was brought in by one of the locums. I said, go and bring her into the clinic. I want to see her. I was thinking, she won't be able to do that. But Margaret came straight in. And the reason she came straight in, she said to us, with her that she would be seeing the doctor on the little TV. And she just thought that was great. She remembered it. It was very positive interaction, and she was happy to come in. So it really improved her access, not just for that specialist visit. It improved our relationship with her. So it's good.
Sorry. And Nova, that is the rockstar advocate for telehealth. She always has amazing stories and accounts to back that up with. So actually, it's true and basic really. For patients, a device like an Android tablet, iPad, or self-notebook device, which is easily transportable. It has just the ability to connect to the internet and have mic, speakers, and camera. Often, our patients live in regions which have poor or no Wi-Fi, and in such cases, it might be best to create a hotspot from your device and connect it. It is important to have a desktop with 2 monitors. Dual mode, as they are known as, is best as one screen is used for viewing the patient, and the other is used for viewing their clinical records. Now that country SAPHN provides and endorses for telehealth, health.com and Jabber, which refer to as health actions.
I have to go. I'm sorry.
No, thank you. Health provider to patient service to connect with patients either directly or with a chosen representative. Meeting rooms inside the app and staff meetings and collaborations can happen. It is easy to share document resources, YouTube videos, and even whiteboards with the patients through Health Direct. Cisco, on the other hand, is a platform that SA Health uses to connect their specialists and allied health through the Digital Telehealth Network, or DTN. We at SAPHN are also using the same platform for our internal company communications and meetings, and a useful tool, especially while working from home during the COVID-19 restrictions. Specialists use MBS items for compensation through telehealth. You can use the same. Health has no software to be downloaded and can be done through Chrome or Firefox, while Kotlia requires just software to be downloaded to your device. I would like to mention why Facebook Messenger, WhatsApp, Skype are not the best apps for telehealth, and then is because they are not encrypted, which means that they are not secure. And Health Connections Video are secure platforms as per the Australian cybersecurity standards, meaning telehealth through Health Connections is safe, secure, and private. So some telehealth for the patient, access to special services which are not local, follow including preoperative and postoperative care from SA Health, reducible, which we earlier learned has great benefits attached to it, share between remote specialists and local healthcare providers, opportunity for in-home health services, and improved familiarity with this, which is a better avenue for patient experience in healthcare. So even digital health in general, patient consent is always number one. VC always require informed consent, and it's usually done before the consult begins. Patients should be reassured that absolutely no video or audio will be recorded during their consults. Telehealth will be an added option of care. There will always be a choice for the patients between face-to-face and video calls. In your consults, patients have the ability to choose who will sit with them, for example, a family member or a health worker. And as telehealth are encrypted and secure. job. What have we looked for? Telehealth works when the provider wants it to. Patients using it, but they just need a little bit of time to get used to it. Practice administration needs to be able to support it and understand how it works. It is easy. It is easy way out, but understand it is a very short-term measure suitable only to known and very simple conditions. But of doing a VC includes the aspect of seeing the patient that has its own advantages of or over, which is audio only. Lastly, telehealth needs to be with your known provider, that is an established relationship, and is not recommended for a new patient, a brand new patient. So these will be sending out when we send out the PDF for this presentation. You can access the MBS items, the permanence of digital health, because it is on the ADHA website now. We have developed some in-house resources, such as the patient information sheet, e-prescribing brochure, and way to promote TH as a practitioner. And I highly recommend going to the Health Direct resources, which can help you inculcate a culture of using telehealth at your practice. So just for demonstrations on how to use Health Direct or Java, or further information on telehealth, for telehealth related staff training or refreshers, or even implementation of telehealth at your practice. Thank you to Anthea for all of her efforts. Unfortunately, she was unable to join us today. But her insight and the time she took out over the past month to work with us in developing these resources has been valuable. From our dev team, Sarah, Hannah, and myself, Vatan, I'd like to thank you all for attending the session today, and we hope we can continue to assist all of our providers to provide clear access to healthcare for those who need it most. Thank you, and Palya.
Before we do close off, I just want to ask if anyone has any questions right now around telehealth. Another thing which I've raised with Tess and which we're conscious of is what we patient end support number. So if your patients are going to be seeing an SA health specialist or any specialist at all, the care item number, which can be used by an Aboriginal health worker to support that visit. Well, it's around $40, $40 dot. So it's 1983. It's important that you're conscious of this because we need that patient end support, particularly in situations where the communication could be quite complex. But there's a tremendous advantage in having telehealth with our specialists because it does enable for much better clinical handover, clear communication between the specialist and the healthcare providers at the Aboriginal Medical Service. So please consider this as a benefit for how we can provide access to our patients, as in improving clinical outcomes and improving the communication between the specialist and yourselves. And it's also important to note that your specialist is not spending 14 hours to come and see you. They have 14 hours to consult with your patients. Travel time actually greatly reduces some of the availability we have to those specialists who are willing to work with Aboriginal and Torres Strait Islander populations. Flag, in the next year, you will be seeing the rollout of the Foot Complications Working Party that have been working on a program for foot support, which is podiatry, enhanced vascular access, and other information being available to you, and they are heavily based upon the use of telehealth. As Tess, you probably gathered from Tess's experience, the thing that most enables telehealth is you. You wanting to use it, you being willing to support it being used with the client, and for you to have confidence in its use. If you just want to use it as a way of communicating to each other right now, to test it out and to be familiar with its use, can you consider use of Jabber instead of a phone call? we're happy to set you up with Health Direct accounts. You probably already do have access to Health Direct to do meetings with each other, but just being familiar with the platforms in themselves for your own everyday work purpose will enhance your capacity and to use them with your patients. So, here, we recorded it. Hope it's too boring. Thank you very much for joining. And so, just checking, any questions after I've now labelled the point? Unmute you. Silence. You're all unmuted. No one's saying anything. You're stuck.
Afternoon coffee, I think, Sarah.
Oh, I can pop out and grab my
No, it's been really clear and clarifies a few points, so I can sort of educate our GPs a bit and try and support the practices to encourage that. Although here at PLAS in Portland, they're quite excited about it, so looking forward to getting it sort of running with electronic prescriptions, and they do a certain amount of telehealth with specialists over the COVID time anyway, so that's sort of, I think, may all take notice a bit quicker. So, yeah.
I also see, Carly, a real opportunity to use video conferencing, for instance, in future case conferencing. I think that's something we haven't really dealt with much yet. Well, we've only thought about one provider to the patient. Yeah. Imagine the advantage of having the pharmacist, GP, and the specialist communicating to each other. Wow.
Yeah. This project's been amazing. To have the pharmacist at a GP practice has just been such extraordinary opportunities, but it's trying to make the multidisciplinary meetings sort of, how do we make them work to, work for the patient. So, yeah.
Well, this is your tool, Carly, and so I'm just thinking I might, if you don't mind, Carly, we'll get the chance to give you your own Cisco license account as well. So that will enable you to have your own direct access to the system. So I was going to speak to Helen Stein about whether the pharmacists in these roles would like access to Jabra accounts, because I think you're really cool participants for this in the future. So
I think you'll get a lot of support there. I think a lot of our country would be very keen. There have been a few times when we've been in lockdown. It's been a bit tricky. So
yeah. Slightly.
But it's a great opportunity, and this sort of stuff, it's a good opportunity for us to sort of prove a bit too. So.
Yeah, thanks, Carly, and thanks for being on board. But if I could follow up with you about the evaluation phase for RTPM, I would really appreciate it if you could put your hand up both as a dispenser, but also how we can encourage some of the clients who you have contact with to be participants in evaluation as
definitely. Happy to do that. Just let me.
Brilliant. Sorry. Huffing, puffing and clapping around was not me. It's the bulldog. Letting everyone know. So any other questions from anyone? I must have just amazed you all. So thank you all so much for attending. I know it's coming towards the end of the year. We are all tired, but it is super exciting with what will be happening in the new year. But thank you very much for everyone attending, and look forward to seeing you face to face in the not distant future. And have a very safe Christmas and a wonderful start to the new year. I now mute myself.